Yes, да? Hello, dear colleagues. How are you? My name is Berdikhojayev, and екі операция. Бүгін екі операция. Тағы біреу болады. We have a patient, young gentleman, 27 years old. He presented with a massive angiofibroma, and we did step embolization for angiofibroma mostly on the right side. It was the most involved part, and the last embo was 5 years ago. All nasal oral cavity it was occupied with the angiofibroma, and then patient received 5 sessions of radiotherapy, and as a result of radiotherapy, the most part of the angiofibroma was decreased, and now this part is on MR looks like a hole. There is no tumor, but the tumor mostly located on the periostal region on sphenoid bone. And after radiosurgery, patient became blind on the right side, and the nasal bleeding stopped 5 years ago, and patient thought that everything is okay, and now at that time I think he thought it could be more calm because the tumor is shrinked as much as possible, but this year the tumor started bleeding again, and the patient asked took him for the angiography and probably occlude the possible bleeding points. And now this part is hypervascular, but if we will occlude this part with the liquid embolic, we might cause necrosis. That's why, for me, as much as possible, we can occlude this part with the coils. There is no particles in the apartment, but with coils we can occlude. This part is still with tumor. The bleeding comes from both sides, and we don't know exactly which part of the tumor is bleeding. And on the left side, the vision is decreased, but still there. That's why patient is scared to lose the vision on the left side, and he's asking to occlude as much as possible, as it's not so regular patient. There is some hypervascular lesion. Here is a hypervascularity, and we will do as much as possible, and then I think we can send the patient for the microsurgery. Ablay Shohanovich Serikpai in Astana. He's now doing a nice job in basal, craniobasal tumors, and I hope he could help for this patient also. The problem is vascularity. It's a point number 1, and point number 2 is bleeding is another point, and the plastic surgery for defect after surgery is also very important. This part is coming also for alveolus. If we occlude this one, It might be some pain in tooth, but it's temporary. This part and that part. There is no clear part of the tumor which could be accessible. The some part is coming from the ICA. Okay, okay, let's do CT to be more clear. I think we can occlude just the maxillary arteries on both sides, but it will help very temporarily for the short time. It will help very temporarily. Yes, the angiofibroma is very suitable for the radiation therapy, but patient is scary because of the vision loss. He's scared to lose the vision, and I understand him. 27 years, and to be blind is not so comfortable. Huh? It looks like facial artery. This is maxillary artery. Yes, we can take 27 microcatheter and go to this branch. Also this branch might be. Yes, it would be very temporary effect. And after that it should be surgery. There is a dysplasia of the ICA on the right side, cavernous segment. Okay. All these small branches are coming here. Maybe we could go here, do super selective angio and occlude this part. Now in crimps, do it as much as possible. Okay, let's see the CT. Жоқ, Соник, бірде 5-25 ашып бере беріңіз. Yes, this is the right side. Hyperostosis. This part is embolized. And this cavity was full of tumor, but nowadays the tumor is mostly at this part. Okay, just a second. Just a second. We need to change the presets. As usual, I like the Kaizen, but it's only it's only in my point, the Kaizen. And okay, now we can see the images. All this cavity after radiotherapy, it became smaller, but nowadays patient has all these tumors at the wall of nasopharynx, and some part is here. Okay, let's see sagittal. Yes, there is a bony destruction, and yes, it's quite complex. It's quite complex. The most of the tumor was on the right side, and it was shrinked as much as possible, but still bleeding. And his hemoglobin is time to time decreasing dramatically because of bleeding, and we couldn't do more. There are limitations. it's not possible to occlude all this tumor. We will do as much as possible. Okay, for the left ECA territory, we will use coils, and for the right side okay, I need to share the link of the streaming. Yes, it's not so simple, huh? The life is not simple. And the shaker for the liquid embolics is now very noisy. It's time to change it. It's more than 10 years we're using this shaker since the beginning of the department. I will send the link to Ablai, and also we will do MR in a couple of days with the contrast, and then it will be full imaging available. Usually it's a job for the Department of Head and Neck Oncology. Until now it's still not sarcoma, not cancer. That's why patient has chances for the improvement. But the only point is a complication of radiotherapy. Экран жылжытасаңыз, 20 см өзіңізге тартасаңыз, 10 см менен. Все, рахмет. I think we need some marker for this. There is a marker, there is a line, but all the time the same notification. Okay. Now we are in right side, left side? Left side. On the left side, okay. Keep it inside. We will ask for headway. Headway 27 бере салыңыз и чекай обычный бере салыңыз. Yes, we used yesterday neuroslider microcatheter, and for me it's like a stick. With 27 we tried to coil the MCA aneurysm, and we used 27 for penumbra coils, and now we ask to give a 27 microcatheter. Не бересешь? Y connector. Okay. We just occlude the extracranial circulation, but after those occlusions, the surgery should be as much as possible in a short period of time, because the circulation is coming from other extracranial collaterals. It's a collateral rich territory. That's why. Интересно. Что, планировка өтті ма, Дәулет? Планировка өтті ма? Самая лучшая клиника. Yes, my assistant is Давлет Сүйөнбетов, and we are transmitting from live transmission from Presidential National Hospital in Almaty. The full name of the hospital, National Hospital of the Medical Center of the Presidential Affairs Administration of the Republic of Kazakhstan. Yes, just the Presidential National Hospital, Almaty City. And yes, we have very effective hospital administration. And now we have limits monthly for 15 cases. And we're receiving material only for 15 cases, but we are doing more than 15 cases. Yes, for Saturday and Sunday it was 11 cases, and today we have a couple of cases. The next case will be brain aneurysm. 2 aneurysms on the PCA territory. Okay, which one is which? Okay, let's check how it's look like on the left side. The right side, for me, we should go to this territory, and we can occlude this territory and some collaterals. I'm not sure how much we can occlude. We can do little bit reflux and occlude this point, but these small vessels will be in place, and they're coming from the that side. Okay, and some small branches coming from the ICA. Let's check the left side. This is the left side, and on the left side these branches coming from ascending pharyngeal. I think it's possible to go here, but with little bit of risk. It's possible just occlude this with coils, ascending pharyngeal, this part. It might be dangerous collaterals, that's why. Okay, let's go to ascending pharyngeal, but first I think we need to occlude with coils this part. Just coil occlusion, okay? This one, and then we will go to here. Now. Yes, it's as much as possible. It's a just coil occlusion, okay? Coil occlusion without penetration with the liquid embolic. Okay, now we are in left extracranial. Yes, and the operating nurse is Madina. The anesthesiologist is Aslı. Anestezistka anlatıyor mu? Anestezistka. Жанна. Yes, the anesthesiology nurse is Жанна. Please little bit. Okay, the brain. The patient is not in ideal position. Внутренний сон доктор му? Okay, in extracranial. If it's an extracranial, we can do a little bit more zoom. Have to go down. Yes, the anesthesiologist is Aslı. The anesthesiology nurse is Жанна. И біздің санитарчиканың аты кім? Назым. Назым is a second nurse. Okay. Stop. Yeah. Ол бір. Now екі. This is the first, this is the second. Yes. Просто спиральмен жауып кетеміз. Қазір ангио жасаймыз ғой. Назад. Плюс. Smart mask. Okay, let's check. Yes, and video support as usual, and thanks presented with the Videon company. Evgeny Grishayev is a owner and boss of the Videon company. Videon KZ company. This one, and then something like 1 second. I need to find this as this branch. As the navigation of headway 27 could be a little bit complex. It's not a 17 micro catheter, and unfortunately the 17 catheters we have a couple on the shelf, but we should use them for the other reason. Okay, now we are here. Okay. Let's check. Normal, пятерка. It would be like a periphery embolization, no? Yes, it's whole territory. For me, it's better to inject liquid embolic, huh? Эмболизация деген дұрыс сияқты. Более дистально не получится. Уже баратын жеріне барды. Then patient will have a toothache. Okay, let's occlude with coils, huh? But for me, yes, if we occlude with the liquid embolic, it would be pain. Okay. Okay, let's take a coils. Шкафта first. Ще алтын бере салшы. Yes, we have some coils from last year. It's nearly 5, 9, 20 coils, huh? Which is Penumbra P400. And yesterday we used for this reason Neuroslider 27, and Neuroslider is very stiff comparing with the headway 27. Okay, we stopped buying the PX Slim catheter. PX Slim is only for the penumbra coils, but we need more universal one. That's why we start to use headway 27 for this reason. Okay. I think we can place a little bit more. It's a penumbra coils. Okay. Так, it was 3 mm, and now we can ask 36. 4 by 8. Или 31 бересіңіз, 31.
Оданша жалпы ма? Үлкен болса жалпы ма?
Жоқ, нормально.
Екіні алмаймыз ба?
Екі аз болсын.
Жоқ, мына прям изгиб жақтан қадап жүреді.
Жоқ, жабылу керек. Little bit more proximal occlusion. As the coil occlusion is less painful for the patient, but it's not 100% effective. Yeah? It's just the afferent occlusion. Yes, you can see how soft, and it's a 4mm coil. It's possible to occlude also the small branches. It's like this, just pull the tail of the coil and it's detached. Well, it's possible to do angiography. That's okay, it would be less and less with stagnation. It's better. But it's very temporary result, it's not permanent. Okay, now we can go to the ascending pharyngeal, and we'll do the same with the ascending pharyngeal. Okay, we'll take this. Торкерді алып шыға сал.
Төмен жағын басып. Төмен жағынан көзілікші. Бар еткенде. Ол бәр жағында тұрғанша қалды. Көйлесі.
Yeah.
Енді бұған көйген шақты байда. Гидрофилмен ма? Ана қайтар қойылды?
Yeah, нормально. Okay. Ascending pharyngeal comes somewhere here, but it comes from that part. It's the occipital artery. It's the occipital artery. It became more medial. I think this one.
Yeah. Oh.
I think this one is ascending pharyngeal. Yes, usually there is a branches. Okay, let's go directly. Let's go into the branch. Okay, Turker verisiz. I think it's little bit became straight. It's a small branch, huh? Small branch goes to the small branch. Okay, now we are in the correct position. Hey, it will not go there. It's usually. Okay. 3'te 8, 3'te 10 не бар, соны бере салыңыз. Okay. Let's check it. Жоқ, пенумбра. Соны бере беріңіз. Okay, this is the upper part. Yes, it's possible to inject from here, huh? But usually it will end with the pharyngeal deficit. 4'te 10 ашып бере салыңыз, келесіз бері. It's a different type, mostly complex 3D coils, but it's a 3mm. That coil may become outside, eh? Okay, no problem. Okay. Now we detach it. It's a very easy detachment. It's easier than Axiom and the Avenir coils. But the only point, it's not possible to cut. It's not cuttable coils. Huh? Okay. If you cut, the coil usually damage. It's only coil, non-possible cutting. Okay, let's do it. It was some branches here, branches here. Yes, just pulling the tail and it's detached. Maybe the Avastin injection could be an option. Maybe, but we have no experience with Avastin. Maybe this year we can start the Avastin experience. Pivots will seam up. Let's see. Okay, I think from this side it might be enough, but let's check what we have till this point. Okay, I will do. Let's zoom. It's from the extracranial. It's not extracranial. But from the intracranial we can see there is a supply, and it's supplying the exact territory with the. No, it's supplying. It's coming mostly from the ICA. It's coming from the ICA and it's coming from the ophthalmic artery. Okay, this could be irradiated, but I think there is a higher risk of optic nerve injury with the radiation. Okay, maybe this part could be resected. Maybe. Okay. Let's see. If it would be growing extensively, then we can go to this territory and resect it. Okay. Then occlude it. Option number 2, it's possible to go with the colleagues from ENT department and occlude. It might be small branches from the maxillary artery going to this territory. Верхняя челюстная артерия.
Барып тұрған жоқ қой мұрынға. Барғанда да емес сияқты қанап тұрған. Алыстады.
Okay. Okay, let's see. We will do control MR in a couple of days, and then we can check. Okay, it's enough with the left side, and now we will go to the right side. Okay. Okay. Не знаю. Вперед чресло. Now we are a little bit selectively in ascending pharyngeal. I will leave my instrument in ascending pharyngeal in maxillary artery, and now we can do angiography from here. It will be most selectively. Okay, it goes from the lingual artery. Вперед. Those branches are going to the territory. Okay. Let's coil this territory. Okay. One. I think it's a branch of superficial temporal artery, or it's look like superficial temporal. It's a subcutaneous. Okay, let's do angio. and then we can decide. И несколько экспансов. Yes, I had a breakfast, that's why it's very tight closing the Y connector with the hub of the microcatheter.
Осыны осы жерден айдап жіберуге жатқан. Маған кетеді, маған кетеді. Әдемі болады.
Минус. Назад. Стоп. Окей. Yes, Matmask. Yeah, okay, let's try to go a bit this way. Cascades. Oh, it's coming. Just a second. Let's check the angiography and then we can decide. Contrast. It's a little bit bleeding, but it's okay. It's a soft tissue. Okay. We can inject liquid embolic. Ask. Yes, it's possible. Menox. Yes, we have a lot of Menox. That's why for this case we will inject Menox. That's okay. It's in soft tissue and we can pull a little bit the microcatheter and occlude the whole territory. It's not a problem. Она дымся genital. Yes. It's just glue. Okay, we don't need to do more than this. It's painful, yes, I know. Okay, it's enough. Yeah. Yes, it's painful, and because of the patient's movement, you can imagine there is no general anesthesia. Yes, the whole territory is small, tiny branches, and all is going to the tumor territory. Yes, now we can go with Sonic to this branch. Just move it. Okay, let's take the Sonic. Yeah, we'll go there. There is so many tiny branches, but I don't think it's necessary to go there. Okay, let's see. Menox pendulum seems. Yes, we have enough Menox. Menox is a liquid embolic from the Metal company. And for the more precise territory, we can use it looks like there is a даже Бермеха. Бредопсис. There is a bifurcation. Now we'll go to this branch, which is it's upper one, and we need to go to the lower one now. Okay. That's as much as possible. Okay, let's check where we are. It's extracranial circulation, that's why it could be a little bit, it might look a little bit aggressive navigation, but it's not so much aggressive. The lateral, we need this shield. Let's check where we are. There's a lot of tumor. Okay. Glue? Rodmat bası. Rodmat bası. Rodmat bası. It's a Menox, huh? Okay. For this year we mixed all. That's okay. That's okay. Glue. We mixed all liquid embolics, and we have not only screed for this year, also the Aptura is available. We ordered 40 vials of Aptura, and I think the only problem could be the quotation and the availability of microcatheters. Okay, it's going to be included. Okay, update. Okay. It's just a part of tumor could be occluded with a very fast reflux. I'm not sure. Should we penetrate more? Şu kutu turamız mı? Или тарта верим? Okay, let's wait for 2 minutes. 2 minut күтетірек. Let's wait for 2 minutes. Yes, that's why I'm working on possibilities of private practice. Let's see what we can do. Ең соңғысын көресіз? Ең соңғысын көресіз? Ең соңғысын, бұдан кейінгіз. Let's wait for. Yes, and we're still working on large focus defect, small focus defect, large focus used for small focus defect, and it will work till the machine will kaput, and then we can stop after that. Okay. Okay, it's approximately 2 minutes. If it would not penetrate distally, then we can stop. It's penetrating. It's also going as a reflex. Took it back. Yes, I am injecting during the retrieval. So there's some side branches. I'll include this part also. Okay. It was just a branch occlusion. Okay. Okay, I think it's enough. We will ask to do control MR in a couple of days to check the situation after, and also we'll send all MR images to Ablai, to Astana, and we'll see if it's possible to resect. But it's too bleedy tumor, huh? Okay. Some part is still functional. City. Get that seriously. Жень? Okay, dear colleagues, the CT is ready. You have seen the CT before. We specially made the CT before, and now it's after. I think nothing special. It was a little bit extravasation here, but we stopped the extravasation, and I hope it would be without any effect for the patient. Now we will stop this case. There is too many short, dangerous feeders which could be radiated or which could be resected. As the bleeding, there is a lot of bleeding risks, and we will see. We will send the images of the patient to Astana Presidential, to our colleagues, and we'll discuss the next step. Okay, thank you for watching. The next case in next 1 hour. The patient just arrived to the hospital, and now the anesthesiology team will check the documentation, and then if everything is clear, we will start in 1 hour. It would be under general anesthesia, aneurysm case. Thank you for watching. See you in next 1 hour.